Before discussing cartilage pathologies, let us briefly review the normal ultrasound appearance of articular cartilage in the knee joint. Normal articular cartilage appears hypoechoic, often nearly anechoic. It forms a smooth, homogeneous layer with a clearly defined superficial surface. At the level of the femoral condyles, the average thickness is approximately 2 mm. If the cartilage measures slightly less, for example around 1.6 mm, but remains uniformly anechoic with a smooth contour and consistent thickness across the examined area, it should still be considered within normal limits. We will now move to representative ultrasound images. This image shows normal articular cartilage in the transverse plane at the level of the intercondylar trochlear groove. The cartilage layer is smooth, homogeneous, and uniformly hypoechoic. The superficial contour is regular and the subchondral bone line is sharply defined. Here, in the longitudinal plane over the medial and lateral femoral condyles from the anterior approach, the cartilage again demonstrates uniform thickness and a smooth surface. This corresponds to the femorotibial joint surface. In the posterior approach, with the patient in the prone position, the medial femoral condyle is visualized. The articular cartilage appears smooth and regular. The posterior horn of the medial meniscus and the semimembranosus tendon are also visible. Here, the lateral femoral condyle is shown from the posterior aspect. Deep within the joint, the posterior horn of the lateral meniscus can be identified. The cartilage maintains normal thickness and echogenicity. This image demonstrates relatively thick cartilage at the level of the trochlear groove. Such an appearance is commonly observed in children or adolescents. In growing individuals, articular cartilage is naturally thicker but remains homogeneous and smooth. Similarly, over the medial and lateral femoral condyles, the cartilage appears thick but structurally normal. Uniform thickness and smooth surface contour confirm the absence of pathology. We now move to pathological findings. In this transverse view of the trochlear groove, focal areas of grade 1 and grade 2 chondromalacia are visible. Grade 1 represents cartilage softening, seen as mild thickening and slightly increased echogenicity. Grade 2 is characterized by partial thickness loss that does not exceed 50% of normal cartilage thickness. Here, a clearer example of grade 2 chondromalacia is visible. Cartilage thickness is reduced and the superficial surface appears slightly irregular. The depth of the defect remains less than half of the normal thickness. In this longitudinal view over the medial femoral condyle, grade 2 chondromalacia is marked. To the right, an area may appear more abnormal. However, this region illustrates the importance of probe alignment. If the ultrasound beam strikes the cartilage at an oblique angle, not all echoes return directly to the transducer. This may create an apparent irregularity or thinning that is not truly pathological. Accurate evaluation requires the cartilage surface to be as parallel as possible to the probe face. This image presents a comparative transverse view of the trochlear groove in both knees. On one side, grade 2 to grade 3 chondromalacia is visible. On the opposite side, more advanced degeneration consistent with grade 4 can be observed. Grade 3 involves cartilage thinning exceeding 50% of its normal thickness. Grade 4 is characterized by complete cartilage loss with subchondral bone irregularity. Here, advanced chondromalacia is seen in the trochlear groove. Cartilage thickness is markedly reduced. Subchondral bone irregularity indicates progression toward grade 4. This image demonstrates near-complete absence of cartilage over a large portion of the trochlear surface. The subchondral bone is irregular. A prominent osteophyte is visible at the femoral margin. This represents advanced osteoarthritis of the knee joint. In this image, hyperechoic foci are visible within the articular cartilage. These intracartilaginous calcifications represent Chondrocalcinosis. Bright echogenic deposits are seen within the cartilage layer of the patellofemoral joint surface. Here, cartilage itself is not directly visualized. However, the medial joint space is narrowed. Marginal osteophytes are present. The medial meniscus is degenerative and extruded beyond the joint space, clearly tensioning the medial collateral ligament. When the medial compartment presents in this way, advanced cartilage degeneration should be expected on the weight-bearing surfaces of the medial femoral condyle and medial tibial plateau. Definitive assessment requires direct evaluation of the cartilage. This image shows osteochondritis dissecans of the medial femoral condyle in the longitudinal plane. The subchondral bone contour is irregular. The ultrasound beam partially penetrates deeper into the bone, indicating disruption of the normal reflective line. The overlying cartilage appears thinned and more echogenic. This represents a stage in which the osteochondral fragment has not yet completely separated. The same lesion is shown here in the transverse plane. Irregularity of the subchondral bone and altered cartilage structure are clearly visible. Osteochondritis dissecans is sometimes difficult to diagnose sonographically, as the most common location lies near the intercondylar notch, an area that is technically challenging to access. The purpose of this presentation was to demonstrate selected articular cartilage pathologies as they may appear in knee ultrasound examination. Accurate assessment requires proper probe alignment, experience, and clinical correlation. Thank you for watching.